Hello, good evening. My name is David Doherty. Thanks for logging in as we continue our series of our Facebook Live joint replacement talks. Topic near and dear to my heart, and hopefully I can provide you some good information tonight and answer any questions that you might have. So again, I'm David Doherty. Let me go ahead and get this presentation started, and hopefully we can all learn something. What I'd want to talk to y'all tonight about is what to expect after hip and knee replacement. So I know you have a lot of questions. I know that there's a lot of unknown about such a major procedure, but hopefully with going through some of this stuff, you can be a little more comfortable with it and learn a thing or two that can help you make the best decision that works best for you. So again, my name is David Doherty. I am a hip and knee replacement specialist. I went to medical school and did a general orthopedic residency training at the University of Texas at the Health Science Center at Houston. I then pursued subspecialty fellowship training in adult reconstruction, which focused on hip and knee replacements. I did this at Duke University with some of the leaders in the field that taught some interesting techniques and provided me with the background and training I needed to really come back to Houston and provide the care that I thought would be appropriate. So one of the things that drew me back to Houston was performing surgery at our state-of-the-art Memorial Hermann Orthopedic and Spine Hospital. This is part of the Joint Center at Memorial Hermann, and it's operated by our clinical partners there. And just so everybody knows, I am a native Houstonian, something I'm very proud of, and it's really an honor to be taking care of this community and helping Houston people maintain their level of comfort and orthopedic care. So a little bit more about the Memorial Hermann Orthopedic and Spine Hospital and the Joint Center of Memorial Hermann. It's a state-of-the-art subspecialty hospital, all orthopedic, mostly elective procedures, and it is such a special place. It was the first hospital in Houston that gained the gold seal of approval for joint replacements. This is done by an independent evaluator, and it's very hard to obtain. And it just speaks to the commitment that Memorial Hermann and the UT physicians that work there are dedicated to joint replacement care. So it's a fully functional 64-bed, 10 OR facility, completely dedicated to the unique needs of orthopedic patients. There are specialized nurses, specialized anesthesia doctors and assistants. There are specialized physical therapists, all there to ensure that you have the best outcome possible. So we perform thousands of hip and knee replacements each year at that hospital. And we recently have looked at our numbers, and we actually have the nation's best length of stay, meaning the shortest length of stay. And we have a top 5 readmission rate as well, meaning that when we're compared to national high-performing institutions, we stack up very favorably and are providing excellent care. So just so we're all on the same page, let's talk a little bit about what exactly is hip and knee replacement. What is a knee replacement? I think it can be more appropriately described as a resurfacing. Only millimeters of diseased cartilage and degenerated cartilage and the underlying bone are removed from the knee. This is replaced with metal and plastic, but it maintains your body's own ligaments. Your muscles power the knee. They keep it together and they keep it moving appropriately. It is essential to have functioning ligaments and tendons for a knee replacement to work, have stability, and be able to provide that pain relief and function that you want. Sometimes as well, arthritis only afflicts a small part of the knee, and patients could be a candidate for partial replacements. If you see these pictures below here, on the left-hand side, there's examples of total knee replacement and partial knee replacement. You'll see the part replaced on the inside of the knee there, most commonly, which obviously maintains the vast majority of your own native knee, which leads to quicker recovery, higher function, all of the benefits of just keeping your own anatomy. On the right-hand side of your screen, you'll see some common knee replacement systems I use frequently in my practice. So the goals of knee replacement remain the same as they've always been. It's to decrease pain and to improve function. Most knee replacement systems, they're made of metal alloys, titanium, cobalt chrome, things like this, well studied, used for years in orthopedic procedures. And then inserted between the metal is a very strong and very tough, but it's very smooth plastic piece made of polyethylene that creates this gliding motion. And knee replacements can be attached with bone cement, or they can be press fit into the bone itself with a roughened surface on the back to allow the bone to grow into it for what we call biologic fixation. So most primary knee replacements, meaning the first time it's done, take less than 1 hour to complete. There's some setup time and takedown time, but for the most part, the procedure is efficient, quick, and can be accomplished rapidly. And additionally, in recent years, technologic advances have led to robotic assistance. As you see below, robotic assistance does not eliminate the surgeon. It enhances the surgeon's abilities to make cuts that we have found with studies to improve alignment of components. The trials are still in process to demonstrate the improved outcomes and function of patients with robotic assisted knee replacements, but the future is promising for this technology. So moving on to hip replacements, the hip itself is comprised of the femur, which is the long bone of the thigh. The top part of it has a head and a neck that are inside of a capsule that are seated within a socket known as the acetabulum. This comprises the hip joint. It's the largest joint in the body, and replacing it involves several well thought out steps. First, a hemispherical cup, much like this, is implanted into the socket. A specialized medical tool is used to prepare the socket, and then that roughened surface gets pressed into the bone, and ultimately it will grow into it. Likewise, on the femur, the stem, as you see here in a picture below, is made out of a titanium or other alloy, and the bone is prepared, and the stem actually goes inside of the actual canal of your femur, leaving the top part, the head and the neck, exposed to comprise your artificial hip. Like a knee replacement, hip replacements rely on a patient's own anatomy, their ligaments, muscles, tendons, etc., to maintain, number one, stability, but also to power the hip to move. And as I'm sure you've read, there are multiple ways to approach a hip. There's the posterior approach, anterior approaches, and also lateral approaches as well. All of these are well thought out and have been studied extensively, and each one of them has pluses and minuses, and each one of them ultimately will provide excellent results in the hands of a skilled and capable surgeon. I utilize an anterior-based approach whenever possible for my patients because I believe that it does improve joint stability, and I have seen that the post-operative recovery time can be a little bit quicker with the anterior approaches. So in hip replacements, similar metals and alloys and plastics are utilized as they are in knee replacements, but this is one area where dramatic improvements in the technology of the plastic portion and other materials has led to vast improvements in the stability and the longevity of hip replacements. Most hips in the United States are replaced in a press-fit manner, meaning they are placed into the bone without cement, and during a process of time, about a few months, the bone grows into the implant and creates a lifelong or biologic fixation. This is in contrast to hip replacements that are performed with bone cement. As you see in the graphic below, on the left, the metal is supported by the cement, which interdigitates with the bone, much like a grout, as opposed to biologic fixation, where a roughened porous surface on the coated area of the hip stem encourages bone to grow into the pores, and ultimately this bond is very strong and can be permanent. So, getting to the whole point of why you're here today, what can we expect after a joint replacement? I'm sure there's lots of questions swirling around if you've been told you need a joint replacement, or if you think you may be a candidate for a joint replacement. Who should undergo this surgery? And what other options are there? Can we entertain some conservative treatments first before jumping straight into a joint replacement? If you have decided joint replacement is right for you, how long are you going to be in the hospital, and what goes on while you're in the hospital? And what sort of short-term expectations? What's it like the first few weeks after a joint replacement? How long does it take to get the full recovery? When are you going to be back to normal or doing the things you want to do? When can you go back to work? And most importantly, something I hear a lot of is, what activities can I do? Or more importantly, what activities can I not do after a hip or a knee replacement? So starting with who's a candidate for total joint replacement. So multiple conditions can cause joint pain, joint degeneration, and joint breakdown. But regardless of the underlying cause, a patient with end-stage, meaning bone on bone, and symptomatic hip or knee degeneration should be appropriately treated with conservative therapies. This is the initial line of treatment. And if this treatment fails to control symptoms, joint replacement should be considered. Some of those conditions that cause joint degeneration are listed below, osteoarthritis being the most common that leads to joint replacement. Hip and knee replacements have become well-established procedures that are cost-effective, they decrease pain, they improve function, and they significantly increase quality of life. There are some absolute contraindications to joint replacement. Anybody with an active infection anywhere in their body cannot undergo joint replacement. Tobacco smoking, excessive BMI, which is a relationship of your height to your weight, and uncontrolled diabetes. These are some of the absolute contraindications. Fortunately, these are all modifiable risk factors for joint replacement, meaning they are things we can actively change and intervene with to further optimize a patient to undergo joint replacement. There are some relative contraindications as well. Certain patients with certain conditions that could be better taken care of, and these patients are frequently in my clinic, and we help them find the avenues to take care of some of these conditions. So ideal candidates are generally healthy, seen regularly by a primary care physician. They're over the age of 50, they have normal BMI, and have undergone a conservative treatment program. And unfortunately, this treatment program has failed for them. It's no longer working. One of the biggest highlights of this talk is you are not alone in this process. The most common cause of disability in the US is arthritis. According to the CDC, 24 million Americans have advanced arthritis that interferes and affects their activities of daily life. Simple things like going to the restroom, making meals, getting in and out of bed, just taking care of yourself. It's a true disability. Millions more are affected with arthritis, but have not quite gotten to the point that they are disabled yet. But unfortunately, this is a progressive condition, and without appropriate treatment, it can lead to significant debility. Over 1 million Americans undergo hip and knee replacement annually. More undergo knee replacement than hip replacement, but as you see in the graphic here, the numbers are significantly increasing. Even conservative estimates place several 100% increases on the demand for hip and knee replacements moving forward into the future. It's a testament to the success of hip and knee replacements and also our aging population that is starting to come of age at the time where arthritis begins to significantly affect you. So numerous studies, when you are looking for a joint replacement and if you think you need one, numerous studies have demonstrated that joint replacement centers that perform the highest numbers of joint replacements per year have the lowest complication rates, which makes sense. The people that are doing the most of these develop skills, talents, and systems that they put in place to ensure they avoid some of the negative outcomes that can occur with certain hospitals that don't do quite as many of joint replacements. Every patient is going to have a preoperative assessment with their surgeon. So if you think that you have some joint pain, you're not sure what's causing it, or you've been told by your primary care doctor you have arthritis, you should come in for an evaluation. It generally starts with some specialized x-rays and a detailed physical exam of probably both your hip and your knee to establish a good working diagnosis. Occasionally, patients will have both hip and knee arthritis, and the discussion becomes management of both of these conditions. The most important thing that I've learned in my career is to treat patients and not x-rays. The discrepancy between a patient's symptoms and their level of disability and the x-rays can be enormous. Sometimes they just don't correlate. Often they do, but the most important thing is to identify what a patient's needs are, not what you think they may be based on the x-rays. So I almost always start with a conservative treatment plan, and we will also start discussing optimization of any medical problems that may exist. And then we have, if you've ultimately failed conservative treatment and we start discussing joint replacement, we will have a detailed discussion of what your current activity level is and what your expectation level is in terms of moving forward. And that becomes very important in establishing what realistic outcomes can be for each unique patient. We've briefly mentioned conservative treatment here. Although I do this with every patient, it's a little out of the scope of this talk, and you're going to actually get a detailed discussion of what the conservative treatments are if you tune in next week with my colleague, Dr. Brawley. So just going down the list here: activity modification, weight loss, oral and topical non-steroidal anti-inflammatory drugs, bracing, assistive devices such as canes, walkers, crutches, physical therapy, intra-articular injections, which come in multiple different types and forms. And if you have specific inflammatory or rheumatoid arthritis conditions, there's a whole class of medication that have had significant successes in treating and slowing the spread of arthritis. So jumping right into it, what activities can you expect to do after a joint replacement? So the majority of patients, the expectation that I have and that my colleagues have is that they will continue to do their pre-joint replacement activities, but without pain, or at least a significant improvement in their pain. They may do activities more efficiently, more quickly, and they may be able to even resume certain activities that they had given up prior to joint replacement. But the most important thing is that they are able to maintain their activity level and just do it in a much more satisfying way, because it's not a constant ache, sharp stabbing pain that they're experiencing when they do the things that they enjoy. So the true underlying goal, if you read between the lines, the true goal of joint replacement is to maintain a patient's independence and their mobility. You're giving people the ability to take care of themselves again, because they can get up, they can walk, they are not limited or confined to their home because of their severe joint pain. There have been some great studies over the years that have attempted to gauge what activities are the most important to patients after joint replacement. And validated questionnaires have been developed and sent to patients over the years. And what these questionnaires have really demonstrated is that joint replacement improves function based off of their preoperative level of function. The improvements are across the board. Unfortunately, they do not improve compared to where they were maybe 20 or 30 years ago, but despite that, they are certainly better off function-wise in multiple activities such as squatting, bending, gardening, all the things you see in this picture here that they couldn't do before their joint was replaced. Many patients these days are asking about athletic activities. The population continues to age, the activity level continues to go up. People have higher expectations of what they want to do, what they want to accomplish, and athletics falls into that category. There are certain activities that are very vigorous: running, jumping, tennis, even contact sports, soccer, football, things of that nature that patients ask about and want to do following their joint replacements. This is particularly in a younger group of patients, but still advanced age patients have higher expectations. It's a reality, and we need to be able to meet some of these demands with our joint replacement procedures. The reality is that each patient needs to be treated on a case-by-case basis. It has significant implications: the patient's age, their preoperative activity level, and their expectations. If a patient is a world-class skier and always has been, and has a very high level of experience in that sport, that's a patient that's probably going to be able to ski downhill or whatever once they have their joint replaced, and that would be their expectation. Whereas a patient that's never skied before and has a joint replaced, that might not be the patient that wants to go take up skiing, although it may be a possibility if you gradually work your way into those types of activities. So experience level definitely plays a role into that. I think that one of the biggest improvements over the last 20 years has been the vast improvements in some of the materials that joint replacements are put in with. Long-term survival of implants is certainly affected by the use and the amount of impact they see and receive. But with the improvements in these materials, we are seeing joint replacements last longer, have lower evidence of wear or rubbing down of the plastic part, and these facts lead to greater longevity. The customized postoperative plan is essential because it balances the patient's needs and the immense positive impact that healthy physical activity can provide the general health of a patient. But you also have to balance that with the potential increased risk of the replacement wearing out, the bone or the implant fracturing, or loosening away from the bone. These are all reasons for failure of joint replacement. Fortunately, they are rare and they take many, many years to develop, but it stands to reason that if you're doing activities that involve running, jumping, or contact, this is going to be harder on the joint replacement system, and it will have a higher chance of having a complication as compared to somebody who only walks to and from the store. But I believe that with the discussion with the patient and establishing expectations and discussing things that are important to them, most patients are able to achieve a level of function and activity that is in line with what they expected. I've highlighted some very good activities over on the right-hand side of the screen: walking, riding bike, swimming. These are all fantastic activities because they are low impact, they raise your heart rate, and they're fun to do. So those are the good ones. But of course, we can always discuss if you want to do the other more impactful activities. So just a brief rundown of what to sort of expect when you are coming in for surgery and what's going to happen. So the day of surgery, at our hospital, the current length of stay for a patient undergoing a primary joint replacement is significantly less than a day. That means that a large portion of our patients are going home the same day as surgery. It's a truly outpatient procedure. So hip and knee replacements in the past several years, various centers have demonstrated that hip and knee replacement is a true outpatient procedure, and most patients can meet the basic requirements and be candidates and eligible for same-day discharge. This is also part of your preoperative assessment by both your surgeon and by the anesthesia team. And generally speaking, going into the surgery, we know who is going to be going home the same day versus who may benefit from a night in the hospital. This is all accomplished by improvements in surgical technique, anesthesia delivery, pain control, physical therapy, essentially the standardization of evidence-based medicine, best practice protocols have allowed patients to achieve their immediate postoperative goals in hours compared to what used to take days. So just going through a typical patient surgery experience, the day of surgery. Your day of surgery actually begins days, if not weeks, before you even come to the operating room. It begins with coordination with my office, with the hospital, discussing all of the extensive planning and coordination that needs to happen to make sure you do have a very smooth and good experience. You'll generally arrive about 2 hours before your scheduled surgery time, and you'll meet with a nurse who will confirm your medical history, prepare you for surgery, get you dressed, and give you some medications that the surgeon has ordered, start your IVs, and confirm your medical history and just make sure that everything is in order. Your surgeon will then come meet you. I will meet you in the preoperative holding area. We will confirm that everything is in order. We'll answer any questions that you have. We'll verify your physical exam and we'll confirm the site of surgery. Next, your surgery is performed. You won't remember that part though. You're then briefly taken back to the post-op holding area where pain control continues, and x-rays are probably going to be taken just to confirm the implant positions. Then you're taken to a private room up on the floor where a nurse will oversee your care and help you get acclimated, resume diet, drinking water at first, ramping all the way up to a regular solid diet. Then a specialized physical therapist that works exclusively with orthopedic surgery patients will come. They will evaluate you, make an assessment based on the surgeon's request, and then they will perform treatment. This treatment consists of walking, getting up and moving, acclimating to any assistive device such as a walker or crutches that you may need, and then also learning some basic range of motion exercises and strengthening exercises to ensure that we're going to have a good long-term result. Then, when your pain is reasonably controlled, the therapist has confirmed that you're able to complete the tasks and you're eating, using the restroom, you're a candidate for discharge. This entire process from start to finish takes anywhere from 6 to 8 hours from the moment you arrive at the hospital to the moment you're going home. And as you see, it includes a surgical procedure, the post-operative care, physical therapy, and just getting your pain under control, which is of utmost importance, obviously. Next come the first couple of weeks. So once you go home from the hospital, the goal is to get you home. There are some occasions where a patient may be recommended for a rehab facility or a skilled nursing facility, but more and more studies have demonstrated that there are actual negative consequences of going to another facility as opposed to going to your home, where you're in your home, comfortable environment, around your family members, and around the things that are going to improve your recovery. So the therapist, along with the surgeon, will provide some documents and instructions for you to follow in these first couple of weeks. I believe that the first couple of weeks should be a time to relax. This doesn't mean do nothing, but it does mean that you will have periods where you will stand and walk. These should be brief but frequent. When you are resting and reclining, your legs should be elevated. The swelling, inflammation, pain, and stiffness that comes along with invasive orthopedic procedures can slow you down in your rehab and your progress. Until your swelling comes down, until your wound is healed, until your inflammation improves, it's going to be very difficult to participate in meaningful physical therapy that begins to strengthen your muscles and improve your range of motion. The first couple weeks are the perfect opportunity for you to walk, do gentle range of motion, but more importantly, rest and let your body heal. Your activity level should not be hurting you. It should be encouraging blood flow and encouraging healing. The main outcome I look for at your 2-week follow-up appointment is your level of swelling and if there is wound healing present. Range of motion and strength are later variables that we will work extensively on after your wound is healed and we've gotten your swelling and inflammation under control. Then we move into the phase where we begin to advance activities. So I like to show this curve over to the side. There's time on the bottom and then your performance percent. Whatever we're measuring, it usually starts out with a slow beginning that first couple of weeks, then a rapid steep increase in your activity level, and then you will get to a point where you'll make more slow increases as you start to get towards the end of your recovery. So if you've been dedicated during the first 2 weeks and allowed your body time to heal, most patients will be ready to advance their activities at right around that 2-week mark. This means initiating physical therapy, starting longer walks, maybe implementing a stationary bicycle, and for some, starting muscle and weight training to really start driving the function of the knee or hip replacement. So this is a phase of rapid improvement, and it can last anywhere from a few weeks to 3 to 4 months for most people. Also, with respect to returning to work, depending on the demands of your job and or your leisure activities, you will resume doing all of these during this period of rapid recovery. It's A lot of it is at your discretion, what you feel comfortable accomplishing, but of course, under the guidance of your surgeon and also possibly a therapist that is helping you work through some of your recovery as well. Also of note, for any uncemented joint replacement, hip or knee, but particularly for hips, it's important to avoid impact activities until the x-rays demonstrate the bone has fully attached itself to the metal or a minimum of 3 months has passed. These impact activities can be things such as running, jumping, or anything where your foot is coming off the ground and back to the ground in a forceful manner. This does not include things like walking, bicycle, swimming. Those are all low impact activities. Lots of people also ask, how long until I'm fully recovered? Some people get scared by the answer when I tell them usually it takes a year and a half even for a full recovery. And even after that, some patients are still able to make improvements. For instance, if they've done well and then maybe slacked a little, got a little weakness in their quadriceps muscle or another muscle, that can certainly be improved with regular strength training, which can have improvements on the function of your joint replacement. But with sustained effort from the time of surgery to when you're the best you will be, plateaued, doing well, usually takes about a year or a year and a half. And this is to attain the muscle strength you're looking for, the muscle memory, improved balance, and just getting rid of the aches and pains that may be present because of issues like scar tissue or some stiffness that you're working through. Like we've already said, the vast majority of your improvement occurs in those first few months during that phase of rapid recovery. But you will get to a point where you're not quite fully recovered yet, but the gains become slightly slower. And then right around that year and a half mark, you'll get to a point where you're happy with your joint replacement, you know the ins and outs of it, you know how it's going to react to certain activities, and your overall comfort level with it has improved, and it feels like your joint. The goal is always to have that forgotten joint replacement that you don't even think about anymore. It just becomes your knee or your hip. The typical follow-up schedule that I use for my joint replacement patients is, of course, you have surgery. That's day 0 or week 0. Your first follow-up occurs in about 2 weeks. That is mostly, like I said, a wound check. There'll be a check of the swelling. We'll ask you what sorts of activities you have been doing, and there will be an x-ray evaluation. Your second follow-up with me will be about a month after that at the 6-week post-op mark. This is definitely a more functional check. For knees, we're interested in what your range of motion is because this has some functional implications. We're just looking for any pain, what sorts of things you're able to accomplish with your physical therapist, how far you're walking, things like that. And then we'll also get another x-ray to monitor the progress or look for any changes that have occurred. Your third follow-up, it depends a little bit on how the second follow-up goes. For patients doing very well that are in that just solid upward trend, rapid recovery, they don't come back till about 6 months after their surgery. Patients that are still struggling or may need extra therapy or having a slower rapid recovery phase, they will come back at 3 months so we can again assess them and make sure that if there are any interventions or more therapy that can be done, we can intervene early enough to ensure we still obtain that excellent result after a year and a half have gone by. Then your fourth follow-up follows after that. It'll either be at 6 months or for patients doing very well, it'll be at 1 year. Once you've made it to that point, your joint is hopefully functioning optimally. You're not thinking about it. You're doing activities that you've been waiting to do for potentially years. And at this point, we're in the yearly checkup phase or for some, even every 2 years. The reason for this is just like any man-made object, regular checks and maintenance can be performed. We can identify problems before they become big problems, and we can recommend changes based on what we see on these x-rays before it becomes a major issue. So, brings us to some of our conclusions. Hopefully this has provided some answers for you about what to expect if you're considering joint replacement, if you're thinking it may be for you, or if you've been told you need a joint replacement. There's a common phrase used of, you will know when you are ready. The trick is to find a patient that is starting to enter the progression of severe pain, debility, but not wait too long so they become wheelchair bound or they have a severe limitation in their life. The answer for joint pain that is not end stage or is not causing severe disability for a patient is generally not joint replacement. We should initiate conservative therapy at that point, and if that fails, then joint replacement is an option. And once you're on the cascade and the pathway of arthritis for your hip and your knee, you become an expert in that hip and the knee. You know when it's painful, you know what activities are going to hurt it, and ultimately, after some experience, you will probably know when you're ready for joint replacement. And bear in mind, your activity level will improve post-operatively, but unfortunately, your function will still not be as good as your pre-arthritis function or compared to patients that do not have arthritis at all. But again, function improves after joint replacement. Patients who maximize their conservative treatment first will usually have better reported outcomes. Hip and knee replacements have been shown study after study after study to be safe, effective in pain control, they improve function, they maintain independence, and they improve your entire psychological health. They give you independence, they allow you to do things that have been taken away from you. And the most important thing to always remember is to have an open communication and close relationship with your surgeon. Letting him or her know the specific activity expectations, letting them know what your concerns are, activities that you want to do, activities you're not sure if you can do, work-related activities. All of these should be discussed preoperatively, so both you and your surgeon go into the procedure having all of the information available, which will always lead to better outcomes. I put some websites up here for more information if you'd like to do a little bit more research. The AAOS is the American Academy of Orthopedic Surgeons, and they have a wealth of patient information. You can find my website at drdaviddoherty.com, and of course you can find our entire department's website at the website listed at the bottom there if you'd like to find other orthopedic specialists or learn information about the department. Thank you very much for tuning in. I hope I can help somebody with this talk. I hope you gained some information. And most of all, I hope you come see me in my office so we can discuss your hip or your knee. And if ultimately you do require joint replacement, we can get you to that activity level that you want to be at in a relatively pain-free fashion, in an efficient way, in a fantastic facility that accomplishes all of your goals. So please don't hesitate to call me, look me up, and I'll see you in clinic. Thank you very much.